All right. It is my pleasure to introduce our last speaker for this morning, Dr. Anoop Bharani. Dr. Bharani is Associate Professor in the Brookdale Department of Geriatrics and Palliative Medicine here at Mount Sinai, where he serves as Associate Program Director of the Hospice and Palliative Medicine Fellowship and leads our Hematology Oncology Palliative Care Fellowship track. He cares for hospitalized patients with serious illness and their families. Dr. Bharani trained at Boston Medical Center and at Mount Sinai, and his interests include medical education, palliative care for patients with advanced heart failure, and care of LGBTQ plus communities. Thank you so much, Anoop, for joining us this morning.
Thanks for having me here. So a pleasure to be with you all this morning. I was asked to talk a little bit about kind of a general approach to pain management, and I have no disclosures to report. And so what we're hoping to accomplish by the end of today is to help you have a standardized language for a pain assessment and ideas to train your learners with that, how to categorize pain, determine an initial management strategy using a stepwise approach, how to choose a safe opioid starting dose, frequency, and how to monitor it closely. I'll give ideas both for the inpatient and outpatient side. We'll talk about titration of opioids over what time intervals, what side effects to look for, and how to counsel patients and families on them. And then we'll do some practice on converting between opioids based on some of the resources we'll provide, with the understanding that you'll get a similar type of material for your board exam as well. The thought here is kind of, we'll cover a broad range of the most common opioids. You either have gotten or will get more complex information around specific modalities or medications like methadone, buprenorphine. So we'll talk briefly about those things, but you'll get more nuanced details elsewhere. What I tell the learners that work with me is that, regardless of being in a specialized field, we should take our prior training to approach any symptom that we face. And that might be making sure to do a thorough history and physical exam, how to come up with a differential diagnosis and make sure that's comprehensive as you're thinking about how to approach it. Think about what treatment options are available and then make recommendations based on what the goals of care that you have are and are operating under. I think it's always appropriate to reverse what is reversible and help guide teams in that setting, even if someone has an advanced illness or a limited prognosis. What regular intervals to train your teams, your colleagues around you to reassess, even if you're not able to do it. And then what education and support you can give for ongoing support, not only to your colleagues, but also patients themselves and their families. So you'll get a PDF version of this if you haven't, but this is the pain card that we use here at Mount Sinai, that we give all rotators with us. And so we'll go over this kind of block by block. And we'll use a case of JM as an example to walk through it. So JM is a gentleman with a history of diabetes, hypertension, BPH, and multiple myeloma. He transferred his care to your institution for additional myeloma treatment, and now he's in the emergency room in severe pain. You glance at the chart, you see briefly that his CMP is normal. There's some imaging pending. There's some consultants that have been called, but you don't see any notes yet. So as far as you know, the goals are life prolonging without any limitations. And so what do you want to know? So take 20 seconds to think about, do I have a standard approach to eliciting information about pain? You might have been taught acronyms when you were in medical school or in your training program. And so take a few seconds to think about that. All right. The one we're going to offer you here is called OPQRST. But before we kind of dive into that, recognize that some people may not be able to give you a history. Pain is incredibly difficult sometimes to categorize and obtain objective information around because of it being such a subjective experience, regardless of what you see in front of you. And so some tools you might be able to use and incorporate into your templates, incorporate into your handoffs. Some of these include the Adult Nonverbal Pain Scale, the Critical Care Pain Observation Tool, the Pain AD in dementia patients living with dementia. And so having a standard tool to be able to get some objective data and characterize the trends over time can be really, really helpful. So OPQRSTU. So when was the onset of this pain? What palliative and precipitating factors are there? What makes it better or worse, essentially? What is the quality? That's the Q. What location or region is it in? Does it radiate? Is the R? What severity? And so is it mild, moderate, severe? Can they categorize it via a pain score? T is the timing. How long has it been going on? Is it intermittent? Is it constant? And then the U is how does it impact your life? And so that OPQRSTU ensures that you're kind of coming up with a standardized approach when you're interviewing people. And so let's say for JM, it's been going on for days, he says. He says that when he's still, it's okay. He tried ibuprofen, he tried Tylenol. It did not really make it better. When he's moving around, it makes it worse. He actually had a near fall trying to go to the bathroom. It's a throbbing, sharp pain he describes. And he does have some baseline myeloma pain in his ribs and his hips, but now really a little bit in the abdomen, a lot in the low back, moving a little bit into his right thigh. It's no better than an 8 out of 10, so pretty severe. Right now it's intermittent, and he has not been able to perform his IADLs. He's been largely bedbound. He actually had an episode of incontinence as he was trying to get to the bathroom, and he's very tearful with you in the emergency room, and he says, I don't know if I can keep living like this. So take 30 seconds to think about what is a differential for JM's pain, recognizing that he's presenting to the emergency room. You briefly glanced at the chart, seeing that he has this myeloma history, he's middle-aged in his 50s, 60s. What else comes to mind? So take a few seconds to think about your differential diagnosis. So I'm going to offer a few ideas, and I think it's always good to try to conceptualize as many causes as you can, regardless of what you see in the chart. So in a general category, he's been largely bedbound. He hasn't been moving a lot. Has that exacerbated his pain? Independent of his myeloma, has something happened? Did he have a musculoskeletal strain? Does he have degenerative disease? Does he have a herniated disc or a compression fracture from that fall? The myeloma might have caused that as well, but independent of that, he's been in bed. Check his back. Does he have some sort of pressure injury that's been impacting his pain syndrome? He's on therapy, presumably for his myeloma. He's immunosuppressed. Is he at risk for any sort of infectious syndrome? He's of an age where he's in the second peak of some sort of HLA-B27 associated inflammatory disease. Could he have cord compression from his myeloma? Does he have other comorbidities that put him at risk for vascular injuries? Does he have some sort of penetrating ulcer pancreatitis or metabolic syndrome like hypercalcemia? So the point here is, while your differential might be cord compression, tumor burden, that's differential number 1, 2, 3, 4, and 5. I think it's really helpful to think about other causes to make sure that you're not missing something, and that when you're trying to reverse what is reversible, that you've thought through it. And sometimes you're going to come into contact with teams who haven't thought through that, and you might be actually guiding them on that with your expertise. So now we'll move into categorizing the pain. And so things that I think about are, what is the time course? Is this acute, subacute, chronic pain? And can we characterize this as nociceptive versus neuropathic pain? So nociceptive pain, people will often describe as kind of aching, stabbing, throbbing, visceral pain, gnawing, cramping, colicky. And recognizing that, these words, while common, may not translate across languages or care settings. And so you often are determining kind of what type of pain syndrome you think it is based on what description you can gather from people. And what the primary etiology might be. Neuropathic pain might be described more as numbness, burning, tingling, shock, electric type pain. And so kind of making a categorization or a heading or a headline, as we're so good at, for the pain syndrome might be helpful as well. So in this case, this feels like acute, severe pain. He's saying it's 8 out of 10, nociceptive, sharp, throbbing pain, and most likely related to cancer, which helps guide how we're going to approach the pain syndrome. And so in your pain card or the document that you're going to get, we've now covered box 1, which is the assessment, 2, coming up with a differential diagnosis, and how then to categorize the pain using time course, descriptors of nociceptive and neuropathic pain. There are other types of pain syndromes like nociplastic and other things that you might see in literature, but most commonly kind of distinguishing between nociceptive and neuropathic pain. And those are kind of the first 3 boxes. Now, how do you use a stepwise approach to that acute nociceptive acute syndrome that you're facing in front of you with JM? And so what I sort of offer is a stepwise approach that mirrors a little bit of the WHO pain ladder, but takes into account what you might have available to you, both in the inpatient and outpatient settings. So what disease-directed therapy can we advocate for? How have we talked to our colleagues about that? What is reversible here? What non-pharmacologic therapies can you to employ to try to help this pain syndrome? Is this something about getting out of bed in the hospital? Is it about physical therapy? Is it about encouraging them to walk as much as possible? What sort of interdisciplinary team members can you tap into that are available to you? Massage, art therapy, music therapy, mindfulness-based stress reduction for pain crises, spiritual care. Do you have access to someone, a psychiatrist or psychologist, given sort of the emotions that he's been expressing? You can address those, but also join with other colleagues to try to address what's going on. Then I move to sort of topical therapies. How do I limit systemic therapies overall? So do I think that wound care, lidocaine, topical NSAIDs, do I think that's going to help this person's pain syndrome? Most of the time, most of these agents have low risk, and so I think it's worth trying. And then moving into anti-inflammatories, is there any reason, either because of end organ function or blood counts, that this person could not receive scheduled Tylenol or NSAIDs or a trial of NSAIDs to see if that would help what we think is bony-related pain? What adjuvant therapies do we have access to? So, for example, for bony pain, for myeloma, steroids. Does this person have neuropathic syndrome type pain, which we know may not help kind of acutely, but do we have access to different neuropathic agents that might be opioid sparing? What procedural-based interventions can we tap into? Would a nerve block, so for someone who has myeloma rib pain, would an intercostal block or pancreatic pain from a celiac plexus block might help? And so oftentimes you might even get board questions about what nerve specifically would be blocked to help a pain syndrome. So it's worth taking a look at some of those as well. Would spot radiation, whether palliative in intent, help this person? So could just 1 or 2 doses really help this pain syndrome over a couple of days? And do you have access to that? What IR-guided intervention? So for example, if someone who has an obstruction, a malignant bowel obstruction, would a venting PEG or some sort of intervention be able to help with that, or decompression of a abscess or an infection? What surgical interventions? So for this person, has neurosurgery been involved, orthopedics been involved? And then coming to opioids. And so I think my point here is that while opioids may commonly be employed for this type of pain syndrome, it's important to recognize that we should be using a stepwise approach to get there. And even if it spares 1 or 2 doses or helps us tackle the pain syndrome from multiple fronts, that should always be the goal. A brief comment about kind of neuropathic adjuvants. If someone's in acute severe pain, we typically use opioids in the short term, recognizing that there are therapies like pregabalin, like SNRIs, like TCAs that can help support the long-term management of neuropathic pain syndromes. A brief comment about kind of harm reduction. It's important to recognize that our goal here is not to prevent any pain at all. We recognize that people are going to have breakthrough pain, are going to need pain. Up to 3/4 to almost all patients with advanced cancer are going to have pain that impacts their daily life at some point. And we recognize that we want harm reduction strategies to try to help them take these medicines in the safest way possible. So recognizing everyone should have a Narcan kit with them, regardless of their history, in my opinion. So it's always recommended to discharge someone or include that as part of their pain management strategy? What sort of devices in the home, if there are children, if there are concerns about treating with comorbid substance use disorder, could a lockbox be provided to someone that is someone helping distribute the medicines in their support network? What education can you provide on intent of starting it, how often you're going to see them, expected clinical policies, what our goal is overall with it, and then using your iStop or to get information from multiple states about prior prescriptions and letting them know that you're going to check those things and making sure that you incorporate that into your notes so you can see what they've been prescribed previously. Recognizing that mu receptors are in other parts of the body, it helps guide some of the side effect profile that we're going to talk a little bit more about, and some of the medicines specifically in the spinal cord, as well as the small intestine, as well as in the brainstem, which can impact your respiratory drive. So how do you choose an opioid? I'm going to give sort of the most common ones that we see kind of in a more natural category all the way to the more synthetic category, which is how we think about it as we recognize organ dysfunction or intolerance to certain medications. So for me, morphine is usually my first choice unless there's an absolute contraindication. Tends to be less expensive, more widely available, comes in multiple formulations. So really is the one that we use or reach for most commonly. If someone has severe liver and or kidney injury, it may not be the best choice given some of the metabolites that might accumulate, which could be a potential board question. Oxycodone is a common one that you might see in surgical or oncologic practices. It's usually not the one that I reach for first because it sort of straddles this line between morphine and dilaudid or hydromorphone. It's often just based on kind of recent history and cultural or kind of stigmatizing experiences in the news and things like that. Often harder to obtain. It has more street value. Many pharmacies may not stock it. You might have to get a prior authorization for the long-acting form. So because of that, we tend not to use it. And the IV formulation is not available in the US. It is in Europe. And so when someone comes to the hospital and they may need to switch, it becomes a little bit harder to think about it. We encourage you to avoid Percocet just because it might limit, based on the Tylenol, how much oxycodone you can use, unless there's a strong reason to use it and they're on a pretty minimal dose. We would encourage you to kind of separate them. With Dilaudid, a little bit better with end organ dysfunction. For us in New York State, for example, it's really hard to find the long-acting formulation. I trained previously in the Midwest where it was more readily available. So just kind of noting in your geographic region what's available, what local pharmacies. We keep a running list of pharmacies in our department in terms of what we've had experiences with so that people can have a better understanding when they're making recommendation independent of effect or kind of the math. We want to make sure that it makes sense for the local area that we're working in. Dilaudid also has multiple formulations. It can be, it comes in oral and IV, but also can be made in a liquid form as well. And of note, the IV formulation tends to cross the blood-brain barrier more easily, often giving a more euphoric side effect profile. So just something to think about, or people might report that to you. Kind of becoming more synthetic, fentanyl tends to be better with more end organ dysfunction, also has multiple formulations, although intranasal tends to be a little more variable in its absorption. Relatively faster on and off compared to other opioids, so you often see it in emergency rooms, ICU settings. You may not be able to use it outside of those settings in IV form, so just determining what your floor protocols are will help you determine what's available. You probably are getting a separate talk on methadone, commonly used, especially in hospice-based community settings. Given some of the access is better, it's less expensive, also comes in multiple formulations. It does have a really long half-life, so often is not used in acute severe pain. We would recommend against auto-dividing what someone is using for cravings in substance use disorder into pain, unless there's a clear indication, because it's going to also involve you working with their addiction medicine specialist or whomever is prescribing their methadone. And the math can be a little more complicated, so important to kind of work together and find someone on your team that you can bounce and make sure that you're doing the math correctly. Then you'll likely also get a talk on buprenorphine, which is becoming more and more common. We are seeing more and more patients admitted already on buprenorphine at baseline, given that it's moved to a Schedule III drug. Also, multiple formulations that you can use, which you'll talk more about, sublingual patches, and most of the time on the inpatient side where I am, depending on the situation and the syndrome and the length of stay, we often keep the buprenorphine patch in place and treat through it with higher doses of PRN opioids. Again, getting support from your colleagues. We encourage you to avoid tramadol, especially in your geriatric population, given some of the interactions with other medications. So what starting doses should you use? So for morphine, we typically recommend starting with 5 to 7.5 of PO, 2 of PO dilaudid, and 2.5 to 5 of oxycodone. The liquid form often is 1 mg per ml or high concentrate 20 mg per ml. And so it gives you a little more flexibility to titrate that, especially if someone is frail, has some impending organ failure that you're worried about, maybe could go either way in their clinical course. So you just want to be a little more careful. Or you might be using it for dyspnea, for example, in which lower doses have been proven to be more effective. So maybe that liquid morphine, it makes more sense. Most of the time, people will use a half a 15 milligram pill, break it in half, and 7.5 as a starting dose. If someone has end organ dysfunction, starting with dilaudid or hydromorphone, we recommend 2, although it does come in 1 milligram as well. And for severe pain, 2 to 4 of IV morphine, 0.2 to 0.4 of IV dilaudid. So should be easy to remember, 2 to 4, 2 to 4. Similarly, starting low, going slow with 0.2 of IV dilaudid or 2 of IV morphine, and then increasing from there. You'll often go to the ED where people have gotten 4, 6, 8 right off the bat. And so recognizing that our patient population tends to have other comorbidities or are a little more susceptible to side effects, we tend to start low because you can increase it within 10 or 15 minutes for an IV medication if you wanted to. So how often are you going to give it? If someone is having intermittent pain, like JM is, we're going to give it as needed or PRN, and we're going to base that around peak effect. So up to 15 minutes for an IV, up to 60 minutes for oral. So you want to wait that long before giving the next dose. And your nursing colleagues will not be happy with you if you order something every 8 or 15 minutes, unless it's in a PCA. So oftentimes the limit on a floor might be Q1 PRN, Q2 PRN. So people often get worried, oh, every 1 hour, every 2 hours, that seems like a lot. And you can counsel your colleagues, hey, actually, we could have given it more frequently. We're choosing to do this. And that's actually pretty safe. And we're going to have holding parameters in case you're worried. For constant pain, we're going to use scheduled medicine around the clock, and we're going to base that on half-life. Half-life for most opioids, we talked about methadone and fentanyl being kind of on different ends of a spectrum, will be around 4 hours for teaching purposes. And if you want to be a little safe, if someone has end organ dysfunction, a little bit older and fragile, maybe spacing that out to every 6 hours to start. And how do you calculate what someone might need for breakthrough pain? Because we know that people are going to have incidental pain. You're going to take the 24-hour total that you're giving them and calculate 10 to 15% of that. And we'll walk through that. So here, what we've done, just to pause, is that we've talked about a stepwise approach to acute nociceptive pain using multiple modalities. We've talked briefly about neuropathic pain, and while there are some long-acting medications that using opioids are okay in the short term. We talked about how to choose an opioid depending on end organ function, risk profile, availability in the community, and long-acting and short-acting formulations available in the US or other countries, and what you might be worried about, and then choosing a frequency and a starting dose based on the intermittent versus constant pain. All right, so let's talk back to JM a little bit. He's 58. Remember, he's in acute severe pain. We think it's myeloma related, normal labs, and we're waiting for further guidance based on his imaging to see what other teams we can tap into and what other medications that we might be able to give. So for JM, what would we want to try right now? So take 20 seconds to look at these answers and come up with what you think you would want to try. So recognizing that in this case, many of these answers are, quote, right answers in that you could try a lot of these things and it wouldn't be inappropriate to do. And you may have kind of the culture of your system might tell you to pick one of these without having thought through it. But the boards are going to ask you that there's multiple right answers. What makes sense for this person based on, quote, best practices? And in this case, he's opioid naive. He has normal end organ function. He's in acute severe pain, so IV over PO. And so morphine starting at the smallest dose via IV seems like the best choice. A brief note about fentanyl patches. I have seen people get put on fentanyl patches for acute severe pain, and recognizing that a long acting is not the choice in someone with acute severe pain who has not seen opioids before. All right, so what are we going to do in terms of how to write this order for him overall? So take 15 seconds to think about, knowing that he's going to get IV 2 milligrams of morphine. How would we write it? Right. So Q1 PRN, because we talked about the peak effect being 8 to 15 minutes, and we could give it that often. But in this case, most likely it'll be ordered Q1 PRN. Again, you're going to see people order Q2 PRN, Q4 PRN as a standard practice. All of these are, quote, right in the context of where you might be. And on the boards, you're not going to, if it was 8 to 15 minutes, you're not going to get both an 8 and 15 minutes and a Q1 PRN, because those could be pretty similar. And so it's going to be pretty obvious in that setting. And in this case, for 4 and 5, you're not going to start a scheduled medicine when he hasn't seen it and he's having only intermittent pain. And just a brief note about kind of holding parameters. Mine are for respiratory rate less than 10, excess sedation, or confusion. Okay, so let's talk a little bit about dose finding for severe pain. In this case, if you have the ability to go back, you might say, okay, I'm going to give a dose and I'm going to come back in 15 minutes after the peak effect. I'm going to see what happens. And different people do different things. And so if someone is still in severe pain, they could give 100% of the dose that they've gotten so far, the cumulative dose, or even 100% increase from the single dose you last gave. And that's going to give a range, and we're going to practice that towards the end. And I bring it up now because with our work, you're going to see a range, and it's about determining what is the most conservative thing I could do, what's the most aggressive thing I could do mathematically, and what makes sense based on what I'm seeing in front of you. So in this case, we're talking about IV, but if you were at home and you were calling a patient, you might say, okay, I gave this dose of PO, I'm going to wait 60 minutes, I'm going to call them back. But because I'm not seeing them in front of me, I might be a little more conservative, and I have reason to do that. So if someone's in severe pain, maybe 100% increase. If someone's in moderate pain, a 50% increase. Our goal is to try to get the pain cut in half, if possible. And so you keep repeating until you get it under control. And so we're gonna kind of practice that. And then you would add the total amount you gave over that half-life period, or 4 to 6 hours, and that's going to be your new standing or your new PRN dose, depending on if it's intermittent or constant pain. So, for example, and I'll bring your attention just to the bottom here. Let's say for JM, he's in 10 out of 10 pain, and you give him 2 milligrams of morphine like we just talked about, and you came back in 15 minutes, he has no side effects, and he's 6 out of 10. So he's still in moderate pain. And so we talked about how 25 to 50% of that dose, so he got 2, so we'd give him an additional 3, and you come back and he is comfy cozy 2 out of 10. So now you add 2 plus 3, and that would be 5. And so 5 is an appropriate dose that he likely could get. Now, you could argue, hey, I don't want to give all of that. Maybe I'm going to bump it down a little bit to 4. I want to be a little more cautious. I'm waiting to see if radiation is an option. I'm waiting to see if steroids kick in and help. So you can justify sort of that range. And so if, let's say, he had constant pain and 5 was the dose we used, we talked about half-life of it being every 4 hours. And so the 24-hour total would be 5 milligrams, 6 doses, 30 milligrams, and 10 to 15% of that as your breakthrough dose being 3 Q1 PRN based on kind of nursing. So I know it's confusing. It can be complicated. It's a lot, but just practicing over and over again, which we're going to do. So how do you anticipate and monitor for side effects? Most commonly constipation. So you don't develop a tolerance to this or meiosis. So you want to make sure you have a bowel regimen, at least PRN. We commonly use Senna and Miralax, a stimulant and osmotic. Nausea is common, and so encouraging to treat through it and that people are going to develop tolerance to it within a few days, because the last thing you want to do is someone say, oh, I'm allergic to it because I developed nausea, and now you're restricted on being able to use it. Similarly, sedation, a couple of days, people usually develop tolerance to it. And then if someone has myoclonus, respiratory depression, delirium to a place where you're really worried about using it, you might end up rotating or dose reducing in that situation. So we've talked a little bit about titration. And so let's say it's the next morning now, you're checking in on JM. He got 5 PRNs of those 2 milligrams. And the overnight team, they listened to your sign out. They increased it by 100%, and he got to 4 milligrams, and he got 3 of those. So I'm going to tell you he got 22 milligrams total. And now when you round on him, he says, hey, the 4 milligram works, lasts a few hours, but it's difficult to wait for the PRNs each time. And now it's becoming a little more constant. So what should we try next? So take 15 seconds to think about which of these answers makes the most sense for you, knowing that he has normal renal function. Right. So 4 works, no side effects, normal renal function, half-life is 4 hours. And so to remember to calculate your breakthrough dose, add up the 24-hour total. So 4 times 6, 24. 10% of that is 2.4. So somewhere 2 to 3 would make sense as his PRN. All right. So transitioning to a long-acting, we're going to skip that for now. But what I would just offer is that on the card that we gave you, it gives you some of the common formulations that it comes in the communities that you might be in. And the big thing is to help teams anticipate that given the climate that we're in, it may require prior authorization. It may require checking the stock of a pharmacy that you're going to. So just being mindful of that in the days prior leading up to discharge. And so this is kind of that chart that you can reference to say, okay, what am I going to aim for as someone is leaving the hospital? So we're talking about JM again. He's doing well. He's doing well in that standing regimen, only 2 PRNs a daily. You do the math, you transition him to MS Contin. He leaves, he's fine. 2 months later, he's back. You're on service again, and you get notified that he's in the ED. He's getting chemotherapy. He's had mucositis. He hasn't been able to swallow his meds, and now he has an AKI. And they say, what do we do? What do we do with his pain medicines? So take 10 seconds to think about what you might do. So given his AKI, we want to convert to IV dilaudid most commonly. And so let's practice that a little bit. So on your card, you're going to see this ratio that we would encourage you at table 3 to set up every time and to teach others to use it too. So you take the current opioid and dose, and then you match it from the chart here on table 2, and then you solve for X with the new opioid from the chart. And so that'll help you determine what to do. So in his case, And then we'll talk a little bit about cross tolerance. And so everyone with a new opioid, although they're acting on the same receptors, may have a little bit of a different reaction to it. So we can sometimes err on the side of being a little conservative or cautious and decreasing 25 to 50%, especially if someone is well controlled or you're a little bit worried about them clinically, to see sort of how they do first. And so in this case for JM, he's on MS Contin 30 BID at home. So that's 60 total in a day. So that's his dose. If you remember, the current opioid from the chart is here, 30. We're solving for X. And so the ratio here, the new opioid from the chart, if we're going to convert to IV dilaudid, is 1.5. So now we set up the ratio, and setting it up every time to solve for X, we get 3 milligrams of IV dilaudid in 24 hours. And because he's well controlled, it's just a matter of delivery because of the mucositis. Maybe you conservatively decrease by a full 50%, and 1.5 is kind of where you start. And because he's in renal failure, maybe you say instead of every 4 hours, I'm going to give it every 6 hours. So roughly about 0.4 of IV dilaudid every 6 hours, and a PRN based on that 24-hour requirement of 0.2 Q2 PRN. So again, there's a range. You could do Q4 hours, you could do Q6 hours, you could do Q1 hour PRN, Q2 PRN. You could not have reduced for a full 50% and only 25%, or not at all if he was in a lot of pain. So there's going to always be that range. And so always asking, what is the most conservative thing? What is the most aggressive thing I can do? Where does this clinical picture put me to? So in the final few minutes that we have, we'll do a little bit of additional practice. So the first problem that I'm going to give you is I'm going to give you 30 seconds to think about how to convert 16 milligrams of PO dilaudid to IV morphine and decrease by 50%. So I'm going to go back to this chart. And so again, 60 milligrams. So for 16 milligrams of PO hydromorphone, we take what we're trying to convert from. Again, put it over what you see in the chart. So PO dilaudid is 7.5. We're trying to convert to IV morphine. So we're solving for X. And so in the chart, it's 10 milligrams. And so the answer X is 21.3. And because we're going to reduce for cross tolerance, around 10.6. So let's walk through JM one more time to see, in this case, let's say he comes to the ED for the first time in acute severe 10 out of 10 pain. It's constant, nociceptive. He has an AKI, transaminitis. He's never taken an opioid before. And so what would you start with based on the fact that he has end organ function, he's opioid naive, he's in an emergency room, and has acute severe pain? Take 5 seconds to think about that. And so probably are going to pick IV dilaudid, 0.2 milligrams as a low dose or a starting dose, and see how he does. And because he's in the ED, it's severe. IV is the best method because of his AKI and transaminitis. Dilaudid would be better than morphine in this situation, and 0.2 is the smallest dose. So let's say you reassess him and he's still 10 out of 10, no side effects. What could you do after that? So take 10 seconds to think about that. And based on that answer that you pick, you again go back, number 3, and reassess them after an appropriate time interval. It's now 6 out of 10. So moderate, still no side effects. What do you do next? And finally, you go back a last time and it's 2 out of 10. You've achieved your goal. What should your final orders be? So in the interest of time, I'm going to walk you through an example, but I'm going to give you the range so you can see how variable this can be and recognize that there isn't a perfect answer here. And so always asking yourself, what is the range that I can do safely? So we talked about IV hydromorphone 0.2, Q2 PRN because of his end organ function might be a place to start. And so you reassess him and he's had no change at all. So we talked about either taking 100% of the cumulative dose. In this case, he's gotten only 0.2. So 100% of that, is 0.2 again. Or you could do 100% increase of the single dose, which would be 0.4. So if you had wanted to give him 0.2 again, would have been very appropriate. If you wanted to give him a full 0.4 again, but the point is that that's the range. So that's what I put here, somewhere between another 0.2 versus up to 0.4. Then when you came back, it went down to a moderate level. So what do you do next? And the point here is that because it's moderate, maybe we go up another 50%. And so to show you the difference between the math, if you did 50% of the cumulative dose, so now he's gotten 0.2 and 0.2 in that first way, 0.4, 50% of that would be another 0.2. Whereas if you did 50% of the single dose, 0.4, you could go all the way up to 0.6. So somewhere again between another 0.2 and 0.6. And what I tell people is you're making progress towards giving him more. And that's the point. As long as you're making progress towards that, how fast you do it over what time period, that can all be variable. And as long as you know that you wouldn't give him more than probably another 0.6, that's how you would kind of frame that in your mind. And if all of that works together, you can add it up. So in this last example, I'll give you the bottom one, which is we did 0.2, 100% increase 0.4, another 0.6. All of that adds up to 1.2. He has end organ function, so we're going to be a little more cautious with 0.6 or Q6. And given that adds up to 4.8 in a day, 10% of that would be 0.48 or around 0.5 as his breakthrough dose. But if you did it the more conservative way, it could be as little as 0.6 Q6 with 0.3 Q2. So again, a range. All right. Hopefully I didn't confuse you too much, but at the end of this, we talked about OPQRSTU. We talked about time course, acute, subacute, and chronic pain, nociceptive neuropathic pain, and how to categorize that as mild, moderate, severe, using a stepwise approach that has opioids being the last, starting with disease-directed therapy, non-pharmacologic, topicals, anti-inflammatories, adjuvants, procedural-based, and then coming to opioids. How to choose which opioid based on end organ function, frequency, and the monitoring intervals based on what's going on and what unit you're in. How to titrate those up to 50 to 100% depending on what's going on, and how to add all that up. What side effects to be mindful of, particularly constipation, and counseling on how to treat through some of the other ones. And then a little bit of practice on converting using the tables on that chart. So thank you to the team who invited me here to speak. And if you haven't, you'll get a PDF of that entire thing and you'll be able to walk through it again. So thank you.
Thank you so much. We have time for a couple of questions and we have a bunch in the chat. There are two that are sort of related to each other, so I want to start there. One is, Dr. Barani, how do you suggest talking with patients who have severe cancer pain and should take an opioid but don't want to use one?
Yeah, so, many times people have prior history, they may have concerns. So I would encourage you to explore it a little bit and say, tell me a little bit about what's worrying you and see if you can get a little more information. What I often find is that when I actually counsel that, we're going to be here with you every step of the way, trying that in the hospital when you're in an observed setting, hoping that we're using this short term. Here's how we're going to monitor whether you're ready to come off of it and how we're going to monitor it. If there are real concerns about kind of what home might look like, starting something that you won't be able to take out of the hospital, you're right. Like maybe we need to think about that. What the goals are. And so definitely exploring it a little bit more, seeing what types of supports they might have to help them work through some of that, not only from a team-based side, but their support system outside of the hospital to help kind of navigate together and building that relationship, building that trust. You'll often be able to overcome those barriers. And sometimes you may not be, or if you need to get another team member involved, for example, if they reveal to you that they have a comorbid substance use disorder or history. Maybe they have extreme anxiety that's keeping them from. So does psychology, psychiatry, addiction medicine, other members of your interdisciplinary team to help work through some of this, social worker about cognitive behavioral therapy, can that help guide you with them?
That's great. This question is related, but more anxiety on the provider side. Someone said, opioids seem so harmful and I'm concerned about prescribing. Do you have recommendations on how to get more comfortable for somebody who's new to this?
Yeah, I think I appreciate you kind of sharing that. And you're right. I think depending on the environment that you're in, you may be the only provider or one of the only providers that the teams are looking to help with that. And inpatient versus outpatient has very different sort of things to consider. So as an inpatient provider, I'm often supported by being in a hospital with multiple people watching the patient closely, knowing that I have staff and team members who are able to monitor and administer these things in a safe way to make sure that they're tolerated. And so I often feel, much more protected that way. But when it gets really complicated, higher doses, I will turn to my colleagues, even having done this for a long time, and say, hey, can you walk through the math with me? So having a group of people that you can turn to be able to do that, or a group in your clinic where you can be able to say, hey, can we have shared responsibility over some of this? What is the follow-up plan going to look like, et cetera? And so I think it's about comfort and I don't want to say trial and error, but always start low, go slow. Even if the math tells you that it's likely going to be fine, try a low dose first, because your pre-test is going to be that they'll probably be fine. And then you're going to get more comfortable kind of doing it more and more. So that's kind of from the math and like delivery side. Some of the environmental sort of things to think about are a bigger conversation for sure about how to protect yourself and make sure that patients and families are protected in an environment. I actually think of palliative care and geriatrics as a harm reduction strategy with the rest of those things because of your expertise. You're not going to eliminate it, but having your expertise actually reduces the harm. And so I feel like it's worth taking on that risk sometimes because of that.
That's great. Thank you so much for those answers and for this whole talk. We really appreciate you coming today.
Of course. Thank you all so much.